Hi everyone, welcome to our webinar today on HIV and intimate partner violence among Asian American and Pacific Islander women. My name is Nancy and I'm with the Asian Pacific Institute on Gender-Based Violence, and before we begin the presentation, I'm going to introduce the technology. All right, let's see. Usually we have a little bit of a concert here, but for many of you, we have internet audio or voice over IP for those who choose to listen using speakers or headphones connected to your computer, or you can dial in using the integrated teleconference. And I provided the primary dial-in as well as a passcode for this session. And if you need technical support during this session, I encourage you to call iLink at 1-800-799-4510. All right. And then another feature we'll be using today is the chat box, which for many of you is located at the lower left-hand corner of your screen. And feel free to use this feature to write in questions, comments, and engage in conversation with each other throughout the webinar. And we will address your questions at the end of the presentation during the Q&A session. And we may not have time to address all the questions you may have, but we can also provide our email address so you can ask us questions following the presentation. And please note that the chat box is a public chat by default, which means it is open and visible to everyone participating in this webinar. So we encourage you not to share private information or confidential information into the public chat. And let's see if we can do a bit of practice. If you can please introduce yourself in the chat box by typing your name, organization name, and city and state. So for me, I'll be Nancy Lan, AP Institute on Gender-Based Violence, or formerly Domestic Violence, in now Oakland, California. Oh, great. I see some responses. Thank you so much. And let me see that as well. Welcome, everybody. Oh, great. Good to see your engagement. Okay, and last but not least, everyone's favorite question, PowerPoint presentations. And the PowerPoint slides for today's presentation will be shared by email for everyone who registered. And following the webinar, you'll receive a link to a recording after the session. And last but not least, we're going to send you a brief survey about, to get your feedback about this webinar. That we will help inform how we think about webinars and our presentations in the future. And so with that, I'm going to pass the floor to Chick Dabby and Amna Ella for the presentation.
Hello, everyone. This is Chick Dabby. I'm at the Asian Pacific Institute on Gender-Based Violence, and we renamed ourselves from our previous name was Asian Pacific Institute on Domestic Violence. I'm sorry you're going to might get a little bit of background noise, but there's a noontime concert happening in a sort of courtyard outside our office. So I will try to keep my remarks brief, and then Amina will pick it up from there. So I want to welcome everybody to this webinar on the intersections of HIV and intimate partner violence in Asian American and Pacific Islander women. The Asian Pacific Institute on Gender-Based Violence looks at all different types of gender-based violence affecting Asian and Pacific Islander women, and we are a national resource center providing technical assistance, training, some data and research to community-based organizations around the country that serve survivors of domestic and sexual and other forms of family violence. Just one moment. The sound quality is pretty bad. Is there a problem with the sound? Can you let us know in the text in the chat box, please? Okay. Is everyone else muted? Is everyone else muted? Okay. All right. Okay. So I want to emphasize why we took on this issue, there are three reasons. So worldwide, globally, women's infection rates have been surpassing those of men. And so there's a very concentrated attention globally to women's infection rates and prevention strategies that address women's contexts and not just how they were, not just the prevention campaigns that were used to address HIV infection rates in men. Secondly, the White House Task Force has for a couple of years convened to look precisely at this intersection of HIV and IPV and understand the extended vulnerabilities that women in domestic violence relationships have to endure and are exposed to because of their situation. And then the third reason we are looking at the subject is because very high infection rates in other communities draw attention to HIV and IPV intersections in Asian and Pacific Islander populations. Women's infection rates are not addressed that much, and so we really want to be able in this webinar to try to raise awareness and provide some training and solid information about how HIV risk is in the lives of API women. So there are different risk factors often for our communities, and that's what we're going to try and address in this webinar. I'm very honored and happy to introduce Amina Abbas, who has been doing work on reproductive health and this intersection of HIV and IPV for about 5 years now and has a lot of expertise and knowledge to bring all of you. So with that, Amina, please take it away.
Great. Thank you, Chick and Nancy, for the helpful overview and getting us started. I'm very much looking forward to talking with you all for the next hour and 20 minutes or so. Once again, I just want to echo that if you're having any sound challenges, please let us know in the chat box, and we can work to see if we can address those. Otherwise, I'm going to go ahead and get forward. So as Chick mentioned, today's webinar is going to provide an overview of the twin epidemics of HIV and intimate partner violence, with an emphasis on a population that is often overlooked, that is Asian American and Pacific Islander women and girls. Let's begin with an overview of our roadmap for today. We're going to begin by just providing a brief overview and setting the context for what we mean when we talk about both this intersection and HIV and intimate partner violence separately. Next, we'll transition into gaining some insight into the demographics of the communities we're talking about. We'll then discuss the prevalence and impact that HIV and intimate partner violence have, as well as the nexus between the two, and look closely at some of those specific risk factors and insights that uniquely affect Asian American and Pacific Islander women and girls.
Me, that can, something like that is like really obvious. I could be completely wrong. I mean, all that has to be based on fact, but no, I would still say.
Hi. If you're, can you please mute yourself if you're not speaking? Thank you. Great, thank you. And then lastly, once we go through those pieces, we'll then close with some recommendations for domestic violence advocates and HIV/AIDS service providers, and have an opportunity for questions and answers. The twin epidemics.
All guests have been muted. You can unmute your line by pressing *6.
HIV, AIDS, and intimate partner violence are epidemics that are both shrouded in silence, surrounded by stigma, and hampered by the lack of data and investments into culturally and linguistically accessible programs. This presentation, as I mentioned, focused on a segment of the population that, when it comes to HIV/AIDS, is incredibly overlooked in mainstream conversations. That is, Asian and Pacific Islander women and girls. As Chick mentioned, we're focusing on these communities because they face unique obstacles, taking into account both biological and societal vulnerabilities that they face when trying to stay healthy, get tested, and access treatments and supports that they may need. While women have historically been left out of mainstream HIV prevention and treatment conversations, that is slowly changing. There's a now renewed emphasis in both the public and private sectors as research and experience have coalesced to paint an incredibly concerning picture of the marked impact that violence has on an individual's health. Meanwhile, the needs of Asian and Pacific Islander women are often fall out of these conversations. A note about before we go further in this conversation. Today we are going to focus on intimate partner violence, primarily in heterosexual relationships. I want to note that this is not to exclude the very real fact that violence can and does occur in any relationship, regardless of sexual orientation or identity. But we do want to be mindful and focus on the unequal burden that falls on women who are disproportionately impacted by gender-based violence in heterosexual relationships. What does it mean to talk about gender-based violence? Gender-based violence includes domestic violence, that is, violence within domestic relationships, and it also includes norms that place women's health at risk by gaining credibility from both societal and cultural inequities. That is, gender-based violence and oppression are often used as tools to insulate gender norms and expectations from change. They serve to control, punish, and silence alternatives to the status quo. And as the United Nations Entity for Gender Equality and Empowerment notes, gender-based violence, including domestic violence, intersects with HIV and shares a common basis in gender inequalities, intersected with other forms of discrimination, such as that based on ethnicity, age, level of education, socioeconomic status, area of residence, sexual orientation, and many others. Let's briefly make sure that we understand and we have a basis of understanding of what it means when we talk about HIV. HIV stands for human immunodeficiency virus. It is the virus that can lead to acquired immunodeficiency syndrome, also known as AIDS. When AIDS occurs, the body cannot fight off infection and disease. Once an individual has HIV, they have it for life. That's because currently there is no safe and effective cure. The scientists are working to find one and remain hopeful. Meanwhile, with proper medical care, HIV can be controlled. Treatment for HIV is often called antiretroviral therapy, or ART. Antiretroviral therapy can dramatically improve the lives of people infected with HIV and has done so since the mid-90s when it was introduced. That means that today, someone diagnosed with HIV and treated before the disease advances to AIDS can have a nearly normal life expectancy. How is HIV transmitted? Because this certainly impacts the discussion of when we talk about the impact that violence has on health. So in terms of transmission, only certain fluids, that is blood, semen, preseminal fluid, rectal fluid, vaginal fluid, and breast milk from an HIV person can transmit HIV. In order to get infected, these fluids must come into contact with a mucous membrane or damaged tissue or be directly injected into the bloodstream, such as perhaps through a needle from an infected individual or a syringe. One other thing to note when we talk about HIV is this concept of an individual's viral load. The viral load refers to the amount of HIV in the blood. An undetectable viral load occurs when the amount of HIV in the blood is so low that it can't be measured. Now, antiretroviral therapy, or that's the therapy that an individual with HIV often takes to help manage the virus, can really reduce the viral load. This is important because it impacts how HIV may be transmitted from an individual who's infected to an individual who's not, and the type of precautions they're using. Let's now look a little bit about what it means to talk about Asian American and Pacific Islander communities. Asian Americans and Pacific Islanders represent incredible diversity. They trace their heritage to more than 40 different ethnic groups, and they speak more than 100 different languages. This diversity shows the richness of a community that has called America home for generations, but it can also translate into obstacles for data gathering and reporting, as well as tailoring health interventions in a culturally and linguistically sensitive way. Because Asian and Pacific Islanders make up only about 5% of the population, this helps explain why oftentimes they may be overlooked in mainstream public health efforts, despite being the fastest growing groups in the nation. That is, when we look at the most recent census data from 2000 to 2010, Asian American population actually grew 46%. So again, the fastest growing groups in the nation. That's why it's important that we're starting this conversation today and that the API Institute is really helping to build the evidence and research base for what it means to look at HIV and intimate partner violence amongst these communities. Now, some of the key demographic points about Asian and Pacific Islander communities impact their health and their ability to access care and interventions. For example, consider a person's immigration status. Asian Americans and Pacific Islanders span every single immigration status. Many in the community, that is roughly 60%, are foreign-born. This means that they represent a far greater share of the foreign-born population than any other group. And because Asian Americans and Pacific Islanders span every immigration status, their experience when they come to the United States and with our health system can vary widely. For example, the experience of an Indian American woman immigrating to the United States on her husband's derivative visa may be very different than a woman refugee fleeing conflict, perhaps in Nepal, or coming to the United States in search of better job prospects. Of course, immigration and conditions in one's home country are also crucial to understanding when developing efforts to reach immigrant communities and to help provide context. Because as we'll see in a bit, how an individual enters the United States and what their immigration status is greatly affects both their economic and social well-being, as well as their ability to connect with health and social support. I'm going to now shift to talk about both the prevalence and impact of intimate partner violence and HIV within Asian and Pacific Islander communities. Intimate partner violence is at epidemic levels and is, as we said, pervasive in every community. And Asian Americans and Pacific Islanders are no different. 21 to 51% of Asian and Pacific Islander women have experienced intimate physical and or sexual violence in their lifetime. Compare that to the national average. An estimated 36% of American women have experienced intimate partner violence. And again, when we refer to intimate partner violence, it can include anything from rape, sexual assault, stalking, or other physical violence. Now, a note about this range. Why do we see this broad range in the numbers of when we talk about intimate partner violence and Asian American and Pacific Islander women? This range is based on a compilation of studies and disaggregated samples of Asian ethnicities and local communities. Given the challenge in collecting data and releasing disaggregated numbers across the 50 different ethnic groups that span Asian Americans and Pacific Islanders, we have to look at multiple data sources to get a better and more accurate picture of what this looks like in these communities. The lower number comes from a 2010 national survey of intimate partner and sexual violence, which included a sample of about 16,000 people. Now, the burden of intimate partner violence among Asian American and Pacific Islander women varies, and different surveys have provided different insight into some of those factors. Some of the factors that influence and create a higher risk of experiencing intimate partner violence among Asian and Pacific Islander women are those who are at a younger age, those who are U.S. born, and those who have either abused substances such as alcohol or other drugs, or those who have experienced depression. All of these groups have experienced a higher risk of intimate partner violence. Within any community, the manifestations of what intimate partner violence looks like can vary greatly. As we mentioned, it can include physical violence, such as hitting, punching, or slapping, sexual violence, such as forced sexual activity, reproductive coercion, bodily humiliation. Intimate partner violence can also take on a non-physical effect. It can include things like emotional and economic abuse, controlling household finances, for example. Intimate partner violence among Asian and Pacific Islander women can also take different forms, including abuse by family members and abuse by in-laws. For example, a survey of 169 South Asian women who are married at the time of the survey found that the proportion of women who experienced emotional abuse by their in-laws was significantly higher amongst those reporting violence in their current relationship than those who did not report such violence. Put differently, they found that those who had experienced violence in their intimate partner relationship, such as by a husband as the perpetrator, were also found similarly to have experienced abusive factors by their in-law. Now, I want to be mindful that, again, we're talking about incredibly diverse populations and very large numbers of the population. And so we don't want to stigmatize or stereotype across different ethnic groups and across different cultures. Each culture has experienced intimate partner violence in different ways, and again, we certainly don't want to generalize. So the examples we're using today are just that, examples to illustrate how this plays out in some communities. Prevalence and impact of HIV. Of the more than 1 million American women of the more than 1 million Americans who are infected with HIV, an estimated 20% are women. This means that despite the historic lack of attention devoted to half the population, women are very much a part of the HIV epidemic and at risk, particularly as we look at changes in global numbers. Right now, women of color make up the majority of HIV infections, with the majority of those amongst Black women. Young adults are also an important part of the population that have to be addressed, as young adults aged 25 to 44 comprise the majority of new infections, raising concerns about what the exposure to violence across the lifespan looks like when it comes to HIV risk. As we mentioned, Asian Americans and Pacific Islanders comprise only about 5% of the U.S. population and account for only an estimated 1% of the population that's infected with HIV in the United States. Now, this low burden, 1% of the population, doesn't necessarily tell a fully accurate picture because of the way racial and ethnic data is captured. It may underestimate the burden amongst Asian Americans and Pacific Islanders. For Asian American and Pacific Islander women, just like women across every other racial group, heterosexual sex is the most common method of transmission. The numbers tell us that 86% of API women living with HIV contracted it through heterosexual sex. In other words, for Asian American and Pacific Islander women, their risk for HIV infection is directly impacted by their male partner's risk behaviors and their awareness of those factors. since heterosexual sex is the most common method of transmission. According to the Office of Minority Health, that's the federal office, Asian American women are actually 20% more likely to be diagnosed with HIV compared to white women. And in the United States territories, the rate of HIV/AIDS is higher than that in the United States for whites, and that's across both men and women. Why do we see these disparities in the numbers despite the low prevalence? One of the reasons is because Asian Americans and Pacific Islanders have the lowest testing rates for HIV across all other groups. And that's a very important factor to consider because whether or not an individual is tested determines the time of diagnosis, whether HIV may progress to AIDS, and what type of precautions an infected individual may be taking to prevent transmission to their partners. 1 in 5 Asian Americans and 1 in 4 Native Hawaiians and Pacific Islanders living with HIV do not know their status. Amongst women, as we mentioned, Asian American and Pacific Islander women are the least likely to be tested for HIV compared to all other groups. Only about 17%, that's an incredibly low percentage of the population, has ever been tested for HIV, and that's a test across the lifespan. Part of the reasons are multifold, from access challenges to stigma, as well as the mistaken belief that tends to be persuasive, and that is that Asian American and Pacific Islander women are simply not at risk for HIV, which we know from the data is simply wrong. Let's now pivot to looking at the nexus between HIV and intimate partner violence and how these two epidemics are related. HIV and intimate partner violence share a common set of risk factors in which exposure to one can heighten risk for the other. Asian American and Pacific Islander women's risk of contracting HIV and exposure to violence is influenced by certain social constructs of gender, patriarchy, and culture, which together impact a woman's physical health and the degree of control she may have within a relationship. Before we get into these social constructs, it's important to note that women and girls' risk of contracting HIV depends on specific biological vulnerability. And that includes the mode of transmission. That is, how an individual comes into contact with the HIV virus will affect the likelihood of actually becoming infected. So the mode of transmission that is highest for contracting HIV is having anal sex, and it is lowest for oral sex. Age also plays a role in the likelihood of contracting HIV. For example, young women and girls are often at a stage in their lives where their genital tracts are still developing. That is, they're often less mature and sensitive and prone to tearing. This is concerning because it means that it can create the opportunity for HIV transmission, since HIV has to move across the mucous membrane in order to be transmitted from one individual to another. The vaginal tract can operate as a mucous membrane, and that is when a young woman or girl is still in development and experiences sexual violence, it can create a likelihood of a vaginal tearing and offer an opportunity for HIV transmission. The presence of abrasions in the vagina, as well as other sexually transmitted diseases, can also influence the risk of transmission. And lastly, this is important when we're talking about the overwhelming majority of infections occurring through heterosexual sex, is that the viral load of the male partner, that is, how much virus the male partner has in his blood, can affect a woman's overall, and a woman's overall health can both play a role in determining whether or not she may be infected with HIV. Violence, of course, has also a marked impact on health and can be both a cause and a consequence of HIV infection. Women who experience intimate partner violence are far more likely than other women to report some of the same factors that impact exposure and a transmission of HIV. These factors including having unprotected sex or having sex without a condom, exchanging sex for money, such as through such as a way of economic necessity, as well as treatment and infection for other sexually transmitted diseases, alcohol abuse, and injecting drugs. Among women with HIV, the rate of intimate partner violence is double the national average, and the rate of childhood physical and sexual abuse is more than double. This suggests an incredibly strong link between HIV and intimate partner violence. Lastly, women in violent relationships are 4 times more likely to contract an STI than other women. And we know that exposure to one STI or sexually transmitted infection can certainly heighten the risk of HIV transmission. One way to conceptualize some of those social constructs that I mentioned a few minutes ago, that is gender and patriarchy, and how they influence women's health and expose women to sexually transmitted infections such as HIV, is to think of the overarching concept of relationship power. Relationship power is simply the degree of control an individual has within the relationship, and that can be influenced by any number of factors. According to an article published in the American Journal of Public Health, women who are at a highest risk for domestic violence are demographically similar to women at risk for HIV infection. This similarity is due in part to the fact that women in battering relationships often have lower relationship power, and that can influence their risk for HIV infection. So how does this concept of relationship power play out? It can happen in a variety of ways and have a direct impact on both physical health and emotional well-being. For example, if an individual is coerced or forced into sex, it can cause a woman can then experience vaginal trauma, thus increasing the likelihood of contracting HIV. A woman may not have the power in her relationship, for example, to negotiate condom use because she is either economically vulnerable and perhaps cannot afford to buy them, or simply unable to negotiate that with her male partner. And then extramarital relationships can expose a woman to risk. Those can particularly be concerning in a relationship that's perceived to be monogamous, and therefore both partners are not using protection in the relationship. How might this play out? For example, a Filipina American woman in a coercive relationship may not have the ability to ask her partner to use a condom, even where she knows or suspects he might have extramarital sexual partners. Or a Chinese American woman might not have the power to negotiate a condom use even in a non-violent relationship, because perhaps in her family, she might have been raised with the belief that condoms are associated with promiscuity. Now, that's certainly a common belief that extends across cultures and is certainly not indicative of only Chinese Americans. Many cultures, of course, have a mistaken view that condoms are associated with promiscuity, particularly when a female partner brings them up. That is, culture is often used to justify the And then lastly, we might see this play out in an economic context. A struggle is finding yourself a partner or she simply and not able to support herself or has few job prospects. And then in addition, the mere exposure to violence is not the only thing that can affect health. The mere threat of violence can also result in non-consensual sexual activity, and therefore, so as we can see, relationship power, or the degree of power that a woman or an individual has within a domestic relationship, can have a real impact on their health behaviors. Factors that are at play includes issues such as culture, stigma, privacy, and shame. Amongst Asian American and Pacific Islander women and girls, and many other cultures, are highly stigmatized topics. As I mentioned, the cultural barriers, while differing amongst the various different ethnic groups, that comprise these incredibly diverse populations sometimes share common traits that can make it a bit difficult to have conversations about sexual health and often relegate relationships to this private sphere. Many cultures, for example, place family above the individual well-being, and so individuals might not feel comfortable talking about sexual health or challenges in their relationships. Stigma about contracting HIV can be incredibly personally and socially isolating, causing an infected Asian American or Pacific Islander woman to have to hide her status from family and friends. For an Asian American or Pacific Islander woman in a coercive relationship, disclosing HIV status can itself create exposure to violence. And then there are the misconceptions about risk when we talk about these communities, both within the community as well as by healthcare providers, and the fear of the consequences of what happens when someone tests positive. As I mentioned before, who exactly is at risk for HIV? Anyone. And there's an often general perception that Asian Americans and Pacific Islander women are not at risk, even when they are, and that the disease is confined to gay men. This mistaken assumption can really have can impact personal relationships as well as testing. And it also has a concerning impact when we talk about healthcare providers, because oftentimes healthcare providers for HIV or recommend testing because they don't perceive these communities to really be at risk. So who exactly are we talking about when we think about Asian American and Pacific Islander who are at risk for HIV and intimate partner violence? We're now going to look at a few slides that are going to provide a snapshot into some of the communities that are particularly at risk. We'll begin first by talking about immigrant women, since it makes sense as 60% of Asian Americans are foreign-born, and as I mentioned before, they span every immigration status. And we know that immigration status can have an incredibly marked impact on an individual's health, including their ability to see a doctor, get coverage, and access care and support, as well as to support themselves economically. How does immigration status affect health? Well, a woman's status, for example, can determine whether or not she can work in the country to support herself, whether or not she has immigration status on her own accord, that is, in her own name, and whether or not she's therefore eligible to access publicly funded health care if perhaps she's struggling economically. Some of the risk factors that can influence an Asian American or Pacific Islander immigrant women's exposure to HIV include transnational spouses. So transnational spouses is a situation where a spouse, for example, may have a family in the United States and a second family in their home country of origin. Or it can include a spouse who travels for work and commutes between countries. In these situations, sometimes one of the partners can engage in sex tourism, therefore exposing the other partner at home to sexually transmitted conditions. And again, because it's often a spousal or marital relationship, there may be the presumption of monogamy and therefore the fact that the partners are not using condoms, both inside the marriage as well as outside, therefore increasing the likelihood of contracting sexually transmitted infections such as HIV. Another risk factor is immigration itself and immigration routes. A woman fleeing conflict by herself or with the company of her children may have to rely on smugglers or people movers to get out of her home country safely and cross borders. And even when arriving in the United States, immigrant women may find themselves locked in detention centers that are themselves not safe and expose them to sexual violence. Relatedly, there are also a number of barriers that impact whether or not a woman can access health care that she needs. Health care being anything from simply getting tested to HIV, being screened for intimate partner violence, or being connected to both physical and mental health care. One of the big challenges for Asian American and Pacific Islander women is linguistic isolation. It can really compound these many other barriers and make it incredibly difficult for a battered immigrant woman to leave her batterer, become economically self-sufficient, or simply communicate. As a whole, 1/3 of Asian Americans speak either limited English or don't speak English at all. This means that when they go to a provider's office, they often can't communicate their needs. Similarly, social isolation can really have a marked impact on health. A woman might arrive in the United States with her partner with no family or community support and feel alone in her new home. This can impact whether or not she feels comfortable seeking help if she's in a violent relationship or going to a doctor for an HIV test. Additionally, legal status has an incredibly marked impact on healthcare. There are two ways. One is fear of reporting and deportation. Right? So depending on a woman's immigration status, she might fear reporting being in a violent relationship, fear, for example, reporting her male batterer's behavior and violence for what might happen to both herself as well as her partner. Undocumented women are particularly vulnerable. If they're in a relationship with an undocumented man, for example, reporting almost any crime can subject an undocumented person to deportation. So there is an incredible stigma against consulting authorities who are perceived to be individuals who are targeting you for deportation. Now, I'll note that there are visas that are geared towards victims of crime. They are limited, and they come with certain requirements. Briefly, that includes U visas, which are visas for victims of certain crimes who have suffered physical and or emotional abuse and are cooperating with law enforcement. Another challenge in the legal status situation is that of women who are here on derivative visas. So an Asian or Pacific Islander woman traveling to the United States with her husband, for example, might arrive based on what is called derivative status. This means that her legal status in the United States depends directly on her husband's status, and it also determines whether or not she can legally work. Most importantly, her presence in the country is entirely dependent on that status. Therefore, her reporting violence or being able to seek care can subject her to concerns about what might happen to her husband's status. This can contribute to a serious also economic imbalance where a woman on derivative status might not be able to hold a job in her own name, and therefore she might be entirely dependent on her husband. There are major restrictions in federal laws that impact which immigrant populations can access which federally and publicly supported healthcare programs. For undocumented women, the situation is quite dire. Undocumented women are largely excluded from federal health programs and can fear reporting crime or seeking treatment due to retaliatory immigration actions. Undocumented women essentially have to rely on Medicaid when we're talking about the federal level. They can also access health care centers as federally qualified health centers, state funded. Stands the law. Vera is known as the fire from law. Personal responsibility and work opportunities reconciliation. Rural health care services, both Medicaid and other public programs. It's known as a 5-year bar. Yep.
Amna?
Yes?
Oh, you're breaking up a little bit. I wonder if you can back up and start over for this current slide.
Oh, yeah, sure. I'm going to go back. Is that a bit better?
Yes.
Great. So I'm going to go back and start with legal status and how that can influence an ability to access health. So there are two ways that legal status can influence the ability to both get out of a violent or coercive relationship seek health care, including HIV testing and treatment. One is this issue of what happens if a woman reports experiencing violence in a domestic relationship. For undocumented individuals, being arrested or convicted of essentially almost any crime can heighten the risk of deportation. That can have serious consequences for a woman who is in a relationship with an undocumented male partner, for example, who is also battering her. Despite perhaps wanting to access help or get out of the relationship, she may also fear having her spouse or her male partner deported. And so that can certainly influence whether or not she'll seek help. There's also the issue of status and the ability to simply work and support themselves economically, as well as access federally funded public health programs, namely Medicaid. So the way that can play out is through derivative visas. So for example, an Asian or Pacific Islander woman traveling to the United States, husband, may arrive based on derivative status. That is, her presence in the country legally is entirely dependent on the primary visa holder status, or that is her husband. Now, derivative visa status also comes with restrictions. Not all individuals on derivative visas are able to work. This means that a woman might come and be completely socially isolated outside of her domestic relationship and also be unable to work. It's going to be an incredibly difficult situation for a woman experiencing violence in that relationship. It could also contribute to a severe economic imbalance where the woman is entirely dependent on her husband in her new home. Another area that both domestic violence advocates and health providers need to be mindful of is the restrictions that federal law brings on access to publicly supported health care. Now, the type of health care that an individual is eligible for is directly dependent on immigration status and, of course, economics. For example, undocumented individuals are largely excluded from federal health programs, and as I mentioned, can fear reporting crime seeking treatment due to retaliatory immigration actions. Undocumented individuals have very few options when it comes for quality, affordable health care. They often have to rely on federally funded emergency Medicaid, which is incredibly limited. They have to rely on health centers, such as federally qualified or state-funded health centers, in which there is never enough health centers or service to provide the need for the community that's eligible for them. Or they can rely on state-funded programs if they live in states like California, New York, or Washington State that have a bit more expansive programs and use state dollars to help care for communities. Another way this plays out is the 1996 Personal Responsibility and Work Opportunity Reconciliation Act, also known as welfare reform. Welfare reform created categories of immigrants known as qualified and not qualified. Depending on which bucket the individual falls into determines whether or not they are eligible to participate in federal public health programs such as Medicaid. It also created a bar that is essentially a 5-year waiting period that kicks in once an individual adjusts to legal permanent resident status, also known as becomes a green card holder. This means that once an individual gains their green card, they have to wait an additional 5 years to qualify for Medicaid. And it can be a lifetime when we're talking about a low-income Asian American or Pacific Islander woman who's really just struggling to get by and in no way can afford private health care coverage. It's important for categories from this requirement. Those include refugees, asylees, domestic violence and trafficking, as well as their derivatives. That's that bucket of categories of people under that 1996 law. violence and trafficking are eligible subject to this 5-year period. So that's an important thing to do. And people immigrate what they might be eligible. Lastly, I'm briefly going to mention the status of COPA migrant women. So COPA migrants, also known as a free association, are individuals who come from the freely associated states of the Republic of the Marshall Islands, Republic of Palau, and the Federal States of Micronesia. These individuals are as non-immigrants under federal law and are permitted special privileges in that they are able to freely travel and work in the United States. Now, that privilege also comes with restrictions in that they are not permitted access to Medicaid or publicly supported health programs despite paying into those programs. It can be particularly hard hit when they arrive in the United States, as they've often fled their homes in search of better economic opportunities and arrive in the United States to work in very low-price jobs, such as the hospitality or food processing centers. And essentially, as I mentioned, they're barred from Medicaid due to federal law. So as we can see, immigration has an impact on the healthcare access and afford. In addition to immigration restrictions and language barriers, some Asian American like Islander women arrive from conflict zones where sexual violence is used as a systematic method of targeted gender-based violence. In 2012, for example, 70% of refugees who arrived in the United States from Burma, Bhutan, and Iraq, half of those granted asylum were from China, Egypt, and Ethiopia. Women arriving from conflict zones frequently experience physical and mental trauma as a result of sexual assault, and they can be further stigmatized by both their families and communities, and often blamed for subsequent HIV infections. Immigrant women may experience sexual assault during relocation to home countries, such as in detention centers or by immigration custodians. For example, just last week, a report issued by the United States Commission for Civil Rights on the nation's immigration centers, and that extensive report raised serious cause for concern, questioning whether some federal agencies are complying with federal law and keeping detention centers safe for both all immigrants as well as children and minors. They're particularly concerning when we look at the exposure of children persons to sexual assault and the carry of enforcement activities by private contractors, where there should be federal oversight. Other areas where this can play out is women who perhaps are fleeing areas that are prone to regional violence as well as natural disasters. Most recently in Nepal, women and girls have been offered self-defense classes after the massive displacement caused by the 2014 earthquakes. Women and families have been living in tents, and they've been offered very privacy or protection. And this can complicate an already stressful and difficult environment and expose women to an increased likelihood of violence. And there's also, across the Nepal and India border, been an increase in trafficking of children. And, you know, when you have or an individual who's comfortable in an area of natural disaster, keep in mind the context of what's happening in their home and how that might have affected both their exposure to violence and their health ramifications. Transgender individuals. Amongst Asians and heterosexuality. One survey, for example, that was conducted on the East Coast, among East Coast U.S. populations, found that about 96% felt that the Asian and Pacific American community has an issue. Certainly, we see similar concerns across all other groups. There can be substantial cultural and economic barriers to both testing and care for transgender individuals. Transgender individuals often have high rates of unemployment that can contribute to being forced into sex work, as well as exposing them to sexual assault and rape. Nationally, transgender persons are amongst the highest risk of HIV exposure. The National Center for Transgender Equity recently found that transgender individuals are 4 times more likely to live in poverty than their general population. So again, creating some severe economic imbalances. Violence is also incredibly pervasive in this community, or against rather this community. One study found that 58%, for example, of transgender women reported experiencing violence in their home. In addition, we're learning more about violence in lesbian, gay, bisexual, transgender, and queer relationships and how they can share similarities and differences with intimate partner violence and heterosexual relationships. So in the context of intimate partner violence and HIV, how can this play out? It can play out in ways such as threatening to jeopardize an individual's immigration status over one's sexual orientation, outing them as either transgender or outing them as a sexual minority. It can also play out in outing a person's HIV status, right? Feeling like perhaps they may be damaged goods amongst their family or community. As we talk about these challenges, we have to remember that for many transgender individuals and LGBTQ persons, their families and their couples and their domestic partners can be the only support system that they have in this country. They can be both dependent on their partner's immigration status, dependent on their partner for simply being able to communicate because they might not speak English very well. And of course, what can't be understated is dependent on their partner for both their social and emotional well-being. And so, of course, that can influence whether somebody reports being exposed to violence, is able to seek help or access care. And it's an incredibly sensitive dynamic that both providers as well as domestic violence advocates have to be aware of. So we've certainly covered a lot of issues when it comes to talking about the HIV and intimate partner violence among Asian American and Pacific Islander women. There are so many factors at play that often it can be confusing as for how service providers and advocates can help address this intersection and really be mindful when treating their client population. I'm going to now offer some recommendations on how we can address this intersection and really help begin to have more informed conversations about these issues. Intimate partner violence advocates and healthcare providers and testing clinics should really cross-educating on these issues and be aware of the intersections and the associated dynamics of intimate partner violence. Remember that while we don't want to generalize across diverse communities and populations, there are specific vulnerabilities when we're talking about Asian and Pacific Islander women that we want to be mindful of. We also want to understand when to recommend a survivor of violence for HIV or STI testing, as well as post-exposure prophylaxis. Post-exposure prophylaxis, also known as, is to be taken immediately within 3 days of potential exposure to HIV. In case you're not familiar, PEP is a medicine that can be taken to help keep the body from spreading and making copies of HIV in the blood. It's often a course of 2 to 3 drugs that are prescribed, and they often must be taken for about 20 days. It's an important option, though it may not always be effective. And because it's often offered in the medical setting, it's important for domestic violence advocates to be aware of the option and understand who they can refer a client to, which is often a healthcare provider. We also need to be mindful that HIV testing and possible diagnosis comes with certain privacy ramifications. Partner notification and diagnosis can increase the risk of physical violence and coercion. We need to be able to work with survivors to help plan adequately. For example, when should testing be recommended? An individual has had unprotected sexual contact. Testing is often recommended at the 3-month mark, and then often at up to 6 months post-exposure. When you're recommending testing to a survivor of violence, you also should be aware of the different types of testing. So there are 2 broad categories of testing, known as confidential testing and anonymous testing. Confidential testing means that your name and other identifying information will be attached to an individual's test results. These results would go into their medical records and might be shared with a very limited portion of health providers and or their insurance company. Now, as in the case of medical information, HIV status is protected by both state and federal privacy laws, known as the Health Insurance Portability and Accountability Act of 1996. That law heavily restricts who can access an individual's HIV status, even amongst medical providers, and with consent. On the other hand, there is what is known as anonymous testing. This might be an option for some individuals. Anonymous testing means that there is nothing in an individual's test result that ties them to them on a personal level. So say, for example, if you take an anonymous HIV test, you will get a unique identifier, such as a number, that will allow you to go back in and get your test results. Now, it's important to note that anonymous testing isn't always offered in all facilities. And so domestic violence advocates, as well as HIV/AIDS service providers, should be mindful of the differences, as well as when to recommend either, and to be able to provide information about those options to individuals. What happens if an individual tests positive for HIV, and how might that expose them to violence? With confidential testing, that is, when your name is associated with the test information, the test result and an individual's name is reported to the state or local health department. And that is to, of course, help public health officials get better estimates of the rates of HIV infection in the state. The state public health department will then remove all personally identifying information about the individual and share that non-identifying information with the Federal Centers for Disease Control and Prevention. Now, depending on your state, there are often also state partner notification laws. State partner notification laws can vary. A state is not permitted to disclose the name of an individual, but they can disclose an HIV status to an individual's partner as well as previous sexual partners. That can expose someone or a woman to violence, for example, if, for example, her male partner gets a call from the state notifying them of potential exposure to HIV, and through a process of elimination, that partner may then go back to the woman and feel as though the exposure came from her. So it's very important to understand this heightened risk of exposure to violence when we're talking about HIV laws. It's also concerning because some states have HIV criminalization laws. HIV criminalization laws are very concerning laws at the state level because they in some cases require an individual to affirmatively tell another that they have HIV before having sexual activity. This can create a situation in which family or friends may try to out somebody's status, right? Or that is threaten to expose them to law enforcement for having not told, or perhaps maybe having disclosed their HIV status and having an individual take advantage of that information. Can also play out in the immigration context, in which a batterer may try to take an individual's HIV status and uses as an excuse to report the individual to immigration enforcement. We also want to understand the lifetime impact that exposure to violence has on both risk behaviors and the ability of someone to take precautions and exercise power in their own relationship. Traumatized and battered women are at an incredibly increased risk of HIV and a segment of the population that we really need to be devoting more resources to. Trauma can affect the degree of success for antiretroviral therapy, for example. Antiretrovirals are the course of drugs that an individual with HIV takes to help manage their condition and prevent it from progressing to AIDS, as well as limiting the likelihood of transmitting HIV to an uninfected partner. Women with HIV who've experienced recent trauma are actually 4 times more likely to have their antiretroviral therapy fail. This can be concerning because it increases the likelihood of that individual gaining infections because their immune system is compromised because of the HIV virus, as well as perhaps speeding up the process of developing AIDS. Trauma also affects the circumstances that can cause a woman to be exposed to HIV as well as affect others. Women with HIV are 5 times more likely to experience post-traumatic stress disorder through any variety of means. And as we mentioned earlier in the presentation, women with HIV are 2 times more likely, that is, to have experienced intimate partner violence than women who are not infected with HIV. So this is why it's very important for both intimate partner violence advocates working with their client populations to ask their patients about their exposure to trauma to help gauge the risk of HIV and whether or not to recommend an individual for testing and connecting them to care. And on the healthcare provider side, it's important to similarly ask about the history of trauma and violence to, again, gauge what their risk is and perhaps needing to connect that individual with an anti-violence advocate. Also, as we've learned, with not just immigration status, but language barriers having such a marked impact for Asian and Pacific Islander communities, both advocates and service providers should really be mindful of what language services are needed and how to connect individuals with appropriate translators or interpreters and having information in their own languages. Lastly, for some Asian and Pacific Islander communities, for some Asian and Pacific Islander LGBTQ communities, we really need to be mindful of the role and power that community and community ties have in both responding to violence and creating accessible support systems. Oftentimes, when we're taking messaging, we may need to adapt it as well as adapt our trainings for staff that are tailored to empowering community members to seek help. For any variety of reasons, may not be able to seek treatment or care that they might need. So I'm going to pause right there. We've covered a lot of material, and I'm sure many of you may have a number of questions. As Nancy mentioned before, we'll certainly be making the slides as well as some resources available to you all. But we're now going to pause and go ahead and see if we have some questions.
Thank you, everyone. You may type your questions into the chat box, which I can then read out loud, or if desired, you can press *6 on your phone to unmute your line. All right, Anna, I have one question from earlier that we can start out with, which is clarifying what body humiliations mean.
Yeah. So bodily humiliation can be situations in which a person is chastised for perhaps in a family for being female, for having different healthcare needs, and perhaps based on the
Anna, are you still there?
Yes, I'm here.
Oh, okay. Sorry. I think people were responding that they were in sound, but we were just, waiting for questions to come in.
Sure thing. While we're waiting for the questions, and people should feel free to continue into the chat function. I'm just going to go ahead and talk about resources, and then we can break if we get some more questions. As Chick mentioned in the beginning, the Asian Pacific Institute on Gender-Based Violence is an incredible national resource center that houses a wealth of information on violence, trafficking, and other forms of gender-based violence within the Asian and Pacific Islander communities. The Institute is, I'd rather say, at the national level. Sorry? I'll go ahead.
Oh, you were breaking up again.
Yeah. So the Asian and Pacific Institute on Gender-Based Violence is an incredible national resource that everyone should make themselves aware of. You should visit their website. They have a large number of resources. Insight into how violence plays out in Asian and Pacific, of the cultural nuances, as well as the data that may be needed to help make the case both within your organizations of why you should be focusing efforts on these communities and helping to really tailor services and care. There are also a number of resources available both through federal partners and nonprofit organizations. The Federal Office of Minority Health has an online minority health resource center that contains up-to-date data and information on a variety of chronic diseases, AIDS. They have data points as well as background on Asian Americans and Native Hawaiian Pacific, and many of those resources are linked in the slides that you'll be receiving after today's presentation. As Chick said in the beginning, we also have a renewed national attention on this intersection of AIDS and violence against women and girls at the administration level. So the Obama administration's White House has issued a report on gender-related health disparities in this intersectional violence, and that's available online. They've been doing work for about the past 3 years, and there's a great wealth of information about the federal partnerships that are available and what different federal agencies are doing, either working with their grantees or working with nonprofit organizations to help build the capacity of domestic violence advocates to both be aware of this intersection and respond adequately, and to build these connections between advocates as well as HIV/AIDS service providers, and really help to cross-educate both populations. Lastly, there are a number of CDC efforts which are also available online, as well as some really great toolkits and a learning module, the National Resource Center on Domestic Violence. It's a great 1-hour learning module and covers a broader overview of what we've covered today, whereas today's the focus has been on Asian and Pacific Islander communities. So I would certainly encourage you to look at the Asian Pacific Institute on Gender-Based Violence website at www.api.org, as well as many of these resources from both federal and nonprofit partners.
So this is Chick. I just wanted to interject here with a couple of points. So firstly, in terms of the resources, we're actually developing a more updated list of resources that are also addressing HIV infection in women. And some of it is, international efforts to address that, but it has, it's very powerful and useful information for us to consider. So that once that is updated, it will be posted on our website, but we're in the process of getting that in good shape. And secondly, the question came up again about some clarification on bodily humiliation. And what I wanted to say is that bodily humiliation is the practice that we hear Asian women reporting to advocates, whereby their family members, not just the intimate partner, but again, male or female in-laws, might mock or sort of make fun of or tease them or actually humiliate them about their bodies. So sometimes women report even being made to sort of take their clothes off, and then family members will comment about her breasts or her body shape or all kinds of aspects of humiliation. And in some communities, what happens with bodily humiliation is that there's a lot of attempt to even then sort of change the body. So sometimes it could just be something like, being forced to shave pubic hair, or it can be, getting plastic surgery to again reshape the body, or to get, your vagina reshaped. So there are lots of different aspects of family humiliation that connect up to sexual violence. And the other piece that of sexual violence, the other type of sexual violence that we hear about from Asian women is the being forced to watch and mimic pornography. And many times in those situations, again, there's a little control over protection, or very little ability to resist, or to decline, or to insist, to refuse participating in certain acts that make women uncomfortable. So in those situations too, there's increased vulnerability. So I would urge us in your different, in the kind of work that you all do, to think about what types of sexual violence do you hear about, what types of, and how those types of violence might sort of increase women's vulnerability. And finally, what are the contexts of immigrant and refugee women's lives in terms of their transnational husbands? Do they go back often? Do they have a second family? Many times women don't even discover that their partner has a second family, and whether that might increase their infection rates. So I think, I just want to kind of iterate in the work that all of you do. We all work in different contexts. We encounter survivors at different levels of need, and different levels of need for health issues, for domestic violence intervention. So what types of sexual violence might there be in the home that would alert you to think about the risk of HIV infection and transmission? Are there any other questions? Okay. So any last comments, Amina, before we wrap up?
No, I think you covered it really, Chick. I just wanted to thank you for the opportunity to discuss this information, and thank everyone who took the time today. I think the biggest take-home message we can take is really just understanding and educating ourselves about this intersection and some of the nuances of how they play out in the Asian American and Pacific Islander communities.
Yeah. Okay. Thank you, everybody. Thank you, Nancy, for all the support and planning around the webinar. And thank you, all of you, all the advocates, for the great work that you do. We know how important it is and how much it means to survivors and victims who are trying to struggle and overcome the barriers that our system set up, and also that our culture set up, and using their own strength to kind of gain empowerment and well-being. So thank you.